Thank you. It's an honor to be here. I was so excited to come to this meeting until I realized I'd been assigned a talk that I don't really know a ton about. No, I'm kidding. But I'm going to present this. I'll just say I'm humbled by the expertise in the audience. So I'm honored to be here, but I want to present this a little bit from a clinician's point of view and where some of the challenges are with pharmacogenomic approaches in cardiovascular disease. Obviously, we know in oncology, even cardio-oncology, there are very good models for this, but for cardiovascular disease, it's been challenging. These are my disclosures. So I had to look this up. So what is pharmacogenomics? And it's really the branch of genetics that is concerned with the way in which an individual's genetic attributes affect their response to a drug. And so that's very specific, but I thought, okay, well, what does that really mean? And I thought of sort of three use cases, and these probably fall outside of the strict definition of pharmacogenomics, but I think the first one is really that you have some genetic mutation or your genetics modify how you respond to a drug, so that there's a formal effect modification, and that could translate into greater efficacy, lesser efficacy, or a safety issue. I think that's the most specific, but there's also, when I think about pharmacogenomics, I think about genetics identifying actually targets that are mediators of risk or risk factors, not just associated with risk. And so PCSK9 is probably one of the best examples of that, right? We learned that there were people that had gain and losses of function of PCSK9 that had better or worse outcomes, and then there were therapeutic targets based on that observation that now improve outcomes for patients. The third then, though, is, and we heard a little bit about this from Scott, is can our genetics identify individuals at higher risk of a bad outcome that can be modified by a drug, maybe even without formal effect modification, just because they're at higher risk, they may derive greater benefits. So just like a subgroup analysis of any trial, these are the people that really benefit. So I'll walk through these. For me, this started back in my TIMI days, and the first generation P2Y12 inhibitor to clopidine had come on the scene for stent protection and other stuff. It wasn't well tolerated, and so clopidogrel was the second generation. It was a thienopyridine, and Cure put it on the map. It was class 1 for acute coronary syndrome patients. Great, everybody felt like we were doing great things with this drug. And then shortly after that, the story came out that actually it's a prodrug. And this is Paul Goebbels' work on the right, which showed about a third of patients at the far left of that histogram that take clopidogrel get almost no antiplatelet effect. And that about a third at the top right get really a robust one. Maybe they're more risk of bleeding. And so that's not really what you want. From a population perspective, sure, in 15,000 patients, it works. But for the patient sitting across from you in the clinic, you have no idea what they're going to get. And the polymorphism, CYP2C19, and sort of good metabolizers and bad metabolizers is well described. Then there were data. This was a New England Journal paper. Jess Mega sat across from me, and Mark Sabatine, and this was data showing that in a large ACS trial, if you had a reduced function allele in the red, that was bad, right, versus those in the blue, and that you had worse outcomes, 50% increase in MACE, and you had a 3-fold excess in stent thrombosis. And the data were so compelling, actually, and this is illegible, but I'll read it for you, that the FDA changed the label for clopidogrel, saying not only should you consider people's genetic status, but there were data that you could actually overcome it by giving higher doses. And this was like the slam dunk for pharmacogenomics. I remember I was with Mark Krieger at our favorite restaurant called El Gigantes, and I was saying we should open an antiplatelet tailored clinic where we can measure genetics and we can adjust doses and so on. So why didn't that happen? I mean, actually, who here routinely measures CYP2C19? You doing everyone? Okay, good. Well, someone did that. That's great. But I'll say that the problem was that data came from this trial. This was Triton TIMI 38, which I was also part of, and this showed that a third generation thienopyridine called prasugrel that was more potent and less variable was just better than clopidogrel. So it sort of raised the question of why bother when you got a better drug. In fact, there was another one, ticagrelor, which came out after. It's not even a thienopyridine. It's a direct acting drug. There's no metabolism needed. There's an active metabolite, faster onset, faster offset, more potent, why bother? And there were outcomes trials for that. I showed you Triton. Here there was actually a mortality benefit versus clopidogrel in ACS patients. It's just a better drug. and albeit a little bit more bleeding, but actually when you look at all the different bleeding scales, not a large amount of excess bleeding. So then there were the prospective studies that said, okay, fine, maybe those better drugs are only better for those when you compare them to patients that have, two CYP19 problems. Maybe if we tailor based on the knowledge, we can improve outcomes. And this is one New England Journal paper that looked at stroke TIA patients. And again, it's a little hard to read here, but there was sort of maybe a modest benefit, nothing really overwhelming. This was a sort of real-world trial from the Netherlands that looked at genotype-guided, whether you use prasugrel, ticagrelor, or clopidogrel. But these drugs are all going generic anyways, and the benefits were relatively modest with a wide non-inferiority margin. So to me, there wasn't a lot of data. I think the best study was probably Taylor PCI, and the upper right-hand corner, this was the MACE outcomes using a genotype-guided strategy versus just conventional therapy, and there was a little bit of a benefit. Didn't quite meet statistical significance. Pretty good hazard ratio, it's just underpowered. But the headline from this was doesn't help, and so it's not routine practice to test. And so what was a great story got surpassed. And to me, when I was kind of thinking about this talk, I thought, why didn't this pan out? Well, first of all, genetic testing is not standard for cardiovascular diseases for most general cardiologists, this audience, withstanding. But this just isn't sort of mainstream to genotype people. Prospective studies didn't really show the convincing benefit. But I think the most important thing was that the development of better drugs is so fast that it really surpassed the need for genetic testing for clopidogrel. If we were still using clopidogrel today as our #1 agent, sure, we'd all be testing, right? You'd want to know, and we'd be doing higher doses. But we have better drugs out there that have surpassed it. So the other story I thought about for antithrombotics was warfarin. These are the early trials. Manesh will laugh at the size of these trials because he's leading this huge atrial fibrillation program. But these are the trials that established the efficacy of warfarin for stroke prevention and atrial fibrillation. And you can see the sum total of events there is quite small, but the message is simple. Anticoagulation works. The problem? Very narrow therapeutic window. To orient you to these graphs, if you're on the left and your INR is low, you have a high risk of stroke. And if you're on the right and your INR is high, the blue dashes go up, that's your intracranial hemorrhage risk. And you have to sit right in between there for warfarin to work and not cause you to bleed in your brain. That's not a great issue. And people have tried fixed dose warfarin versus adjusted dose. But on the left side and on the right side, whether you've had a stroke or not had a stroke, adjusted dose warfarin is better than fixed dose because there's so much variability in how people metabolize the drug. So then there was this trial. This came out in 2009, I believe. This was right around the time of CYP2C19, and it was another drug where we thought the genetics are going to matter. And actually, there are two mutations there. There's CYP2C9 and VCORC1. There's one in the metabolism of warfarin, one in the vitamin K cycle. This was already in the FDA label that you should think about these. And then when available, this can assist in the starting dose. And so they did this trial, and this was actually a positive trial that you can see for people that either needed extremes of low doses or high doses, using a model with the genetics, age, and body weight, body surface area actually helped you pick a better dose. And so this was like, wow, okay, now we're going to be using genetics routinely in our warfarin dosing. Who does that? Does anyone routinely? Yeah. Okay. So and so then this was great, positive, and then there was another trial that came out, and this was from the COAG investigators, and this is the INR, and this is a simple story. There's the dark, which is genotype guiding, and the light, which is clinically guided, and they're just no different, provided zero benefit. But I think this is the real story, is that by the time this came to prime time, actually there were 4 enormous trials of direct acting oral anticoagulants. In fact, 2009 in Barcelona was when the RELY trial was presented. It was the first of the DOACs. It was the same year that the genotype-guided dosing of warfarin was presented. And these drugs are just much better. They're fixed dose. They're equivalent or better for stroke prevention. They reduce bleeding. So I think, once again, when we try to use genetics to solve for a flawed drug, it's hard in cardiovascular disease because we don't all test. That's just not widespread. The prospective studies have struggled to show benefit for that strategy. But I think the more important thing is that drug development is so fast that we're already on factor XI inhibitors. before people can even think about how to integrate genetic testing into it. So I'm a little skeptical of pharmacogenomics to solve for flawed drugs. But what other ways could we think about pharmacogenetics? Well, here is one where we identify monogenic or specific conditions where we can see attributes. I talked about PCSK9, and here's one called factor 11, right? So we notice that hemophilia C patients are protected from thrombosis. They don't tend to bleed. That people who have gain of function for factor 11 don't do so well. And then there's been a bunch of preclinical validation, and this is the sort of holy grail of thrombosis, right? Decoupling at the far right, bleeding and thrombotic protection. And maybe we found it based on this genetic mutation in this group of patients with hemophilia C. And now there have been 4 phase 2 trials that have shown benefit. And I'll just say this just came out this week from Anthos, from their large phase 2 trial, that it was halted early for overwhelming reduction in bleeding versus the 10As, which were so much better than factor 11. So I think this is a real success story for genetics, that hemophilia C is a condition that you can target factor 11. And this will change, I think, is likely to change how we think about thrombosis. I think the other one we talked about already is Lp(a). So Lp(a) is largely genetically determined. We don't have to necessarily genotype you. We can measure the Lp(a), but you kind of have what you have. And this has been well described as closely associated with major adverse cardiovascular events. And this came up earlier. There are a number of studies now that have showed that high Lp(a) is not only associated with the incidence of PAD, but also worse outcomes in patients with PAD when you look at limb outcomes. And this is male events in patients undergoing limb revascularization. That's a very low threshold, actually, for lipoprotein A. These are data that we did in our group. This is from around 50,000 patients in the TIMI data sets. And we just presented this at ESC, and this is the relationship of lipoprotein A, major adverse limb events. This is a molar assay, just so you can understand the relative concentration. And while a hazard ratio of 1.07 doesn't look so high, this is as a continuous marker. So actually, it's quite powerful. And to put it into context, at the bottom of the slide, if you look at the independent risk after adjustment for male, this is amputation, acute limb ischemia, revascularization, it's greater than for MACE. So actually Lp(a) looks particularly important for major adverse limb events in patients with PAD. And here when you look at the different components, what's a little bit, I think, counterintuitive is it's actually athero events that are driving it rather than thrombotic events at the bottom of the slide. And you can see that the risk associated with Lp(a) takes off at about 50 millimoles per liter, which is a very low cut point, meaning that in patients who have disease, Lp(a) may be a very toxic agent. Now, this is exciting for a couple reasons. One is because there are drugs out there like PCSK9 inhibitors that don't just reduce LDL, but also reduce lipoprotein A. And these are data from Greg Schwartz and Michael Zarek showing that there was actually effect modification for alirocumab in the Odyssey trial. Just to orient you to this graph, this is alirocumab versus placebo amongst the different quartiles of lipoprotein A. What you can see at the right there under LDL is everyone got the same LDL lowering. Everyone got about 40 to 50 milligrams per deciliter LDL lowering. But in the top quartile, if your Lp(a) was low, actually that LDL lowering did nothing for you. And if your lipoprotein was high with increasing levels and the decrease in Lp(a), you had a greater benefit. And this begs the question of maybe LDL lowering didn't mediate at least the limb benefit. Maybe it was the lipoprotein A, getting to the subfractions that we talked about. The other thing that's exciting is that there's a whole host of novel therapeutics that are specifically directed at lowering lipoprotein A. And so this is an exciting opportunity to really personalize therapy. And I think of it this way, that actually when I talked to Bob Eckel, who's at University of Colorado, he told me, I've been measuring Lp(a) for decades and no one ever listened to me. Now everyone's all excited about it. But back then, or even now, lipoprotein A is a risk marker. You know, if you have it, it's bad. What do you do about it? You just treat their LDL lowered, control the other risk factors. If these trials pan out, now we can personalize, right? So if you have a patient who has ASCVD or at risk, if their Lp(a) is high, you're going to give them a targeted therapy for Lp(a), and then think about maybe LDL lowering or other targets. If their LPA is not high, then there's no reason to treat that, right? You're going to focus on other things. And so now we begin to see how we can use at least this risk factor, if it pans out, based on their genetic status for therapy. All right, so then the last thing I wanted to talk about was how we identify patients at higher risk that may just get greater benefit from therapies that are generally effective. This is not true pharmacogenomics in the sense of an interaction, but how we identify patients at risk. We do this all the time. In every clinical trial, we dice up all the subgroups and we say, who's at higher risk and gets greater benefit. Here's data from the Fourier trial for major adverse limb events. There was a significant reduction with evolocumab. And you can see on the left side, the PAD patients with a prior peripheral revascularization had a higher risk of major adverse limb events and a greater absolute benefit, 1.3% relative risk or absolute risk reduction versus those PAD patients who'd never had a revasc who were lower risk. But there's no effect modification, right? The hazard ratios are exactly the same. Well, maybe polygenic risk scores can do the same thing for us. Maybe it's not effect modification, but we can say we've identified a group that's higher risk. So a couple of models for this. So VTE, we heard a little bit about that this morning. There are a number of genetic factors. We used to do genetic testing a lot in VTE. We do it less now, but people that had monogenic attributes or monogenic mutations that put them at higher risk. You've seen this graph several times today, but at the upper left, those are the sort of rare alleles causing Mendelian disease. And there's a few of them here that I'm sure all of you have tested before: factor V, prothrombin gene mutation, protein C, protein S. These are monogenic mutations, and there's a variability in terms of how high risk somebody is based on the testing here. And so these are generally useful for individuals in certain settings. I generally test genetics here to understand, why a VT event occurred, maybe impact the duration of therapy, maybe aid in family screening to identify others at risk. Specifically, and it's not recommended to test for heritable thrombophilia in unselected patients, and so it's a very personalized decision of who to test and whether it will change your management. Just give some specific scenarios where I've thought about it. If it's going to change your treatment duration, obviously it's actionable. For very young patients, strong family histories, pregnant women with a family history of VT and a first-degree relative, children with purpura fulminans, and then select asymptomatic first-degree relatives of people with known mutations. These are some areas where you would consider it. And I'll just skip over that. But then what if we move to the right side of the slide, and Scott spoke eloquently about this today, where we have a lot of common variants that have a relatively low effect, and we can put them into a risk score. And so you've heard about polygenic risk scores. I think from a pharmacogenomic perspective, this isn't a specific interaction, but I think we often create our randomized trials selecting for people that are heightened risk for an event. Why not use enrichment with polygenic risk scores? So this is work from Clarence and et al. In Nature Genetics, looking at their VTE genome-wide association study. You heard about this morning, and you can see here that there are strong odds ratios for the genetic risk score when you look at the multiple variants that affect a proportion of the population, so that these do predict risk. And I'll just show you some of the work that we've done in our group. We took 3 of the randomized trials from the TIMI data sets, and I'll explain why in a moment, to validate this. And we looked at the VT risk based on their genetic risk score. We kind of divided them into their tertiles of risk. And you can see that within clinical trial population, although no one had sort of pre-specified this, when you look at the genetic risk using those genetic risk scores, you don't need millions of people. Actually, there's a clear trend for risk in terms of the risk for venous thromboembolism. When you look at the relative importance of the genetic risk stacked up with traditional risk factors for venous thromboembolism, including age, which is, of course, the strongest of all risk factors, you can see that it was a potent risk marker or risk factor, even after you adjust for these things, and there was a greater than 2-fold risk in those with high genetic risk. And that this was consistent no matter who you were amongst all of the subgroups, so whether you were obese, whether you had diabetes, age, sex, and other things. So the conclusion was that this was broadly applicable as a polygenic risk score within these clinical trial populations. So what is the clinical implication to this? Well, I've talked to you about PCSK9 inhibitors. There have been 2 large trials that have shown that PCSK9 inhibitors reduce the risk of venous thromboembolism. Statins do too. But you can see that the numbers are low, and this is a relatively infrequent event. You would never prescribe, if you will, a PCSK9 inhibitor for venous thromboembolism prevention because the absolute risk reduction is just so low. But maybe you could enrich and find a subgroup of patients where the risk is high enough to justify it. So we looked at that in the Fourier trial, and you can see here in the placebo patients that if you had the top third of the genetic risk score, you had an event rate that was more than 3-fold those with a low risk score. More importantly, though, you can see that the effect of evolocumab was much greater in those that had high genetic risk. And therefore, if you were going to, we can talk about this, but if you were going to develop a prospective program to enrich for patients that would benefit from evolocumab for VTE, you'd want to look potentially at their genetic risk score. So the last one I'll talk about is peripheral artery disease. We're focused on vascular disease, and this is part of our SFRN grant with the AHA, looking at the work from Claren and others around the specific mutations associated with PAD, and it's not just incident PAD, but PAD outcomes. You've seen this graph earlier today, and we wanted to see whether we could validate this in the clinical trial data set. So we took multiple randomized clinical trials here. These are all different populations. We actually painstakingly adjudicated adverse limb outcomes in each one of these data sets so that we would have a high degree of specificity. And then we took their genetic risk based on these 19 SNPs, and we divided them into 3 groups again. Again, I know continuous data has more power, but from a clinical perspective, sometimes 3 groups is as much as you can handle. And we looked at the outcomes listed here. We defined male as a composite of ALI, CLI, major amputation, or peripheral revascularization, and adjusted for comorbidities. You can see here the 3 groups that we came up with: low, intermediate, and high genetic risk, and what the differences were amongst them. But actually, from a clinical perspective, they look pretty similar. And then here you see the results that, using the genetic mutations defined in the Clarence paper and then putting them into this genetic risk score, there was a 47% increased risk of major adverse limb events and prevalent PAD with a high genetic risk. And when you look at the other risk markers here, or risk factors, smoking was the strongest, but this was around the order of magnitude as chronic kidney disease or diabetes. So I think an important marker of risk. And so here's the relationship of the genetic risk score. This is PAD score by 1 minus the standard deviation and major adverse limb events. So not only was it predictive of prevalent or incident PAD, but also major adverse limb events. And when you look across the different types of major adverse limb events, it was statistically significant for acute limb ischemia, critical limb ischemia, peripheral revasc. We didn't have quite enough of the amputation events, but I think the relationship is there as well. What's interesting is when we looked at and this came up earlier, and is PAD the same as stroke or CAD? They're obviously very different. We did see that the PAD score predicted MI, but did not predict ischemic stroke, which I think is an interesting observation. All right, so I'll stop here and just say that I think pharmacogenomics is very promising. I think that although there was a lot of excitement around using pharmacogenomics to solve for flawed drugs, that has been a harder place to show value because drug development is moving quickly and just better drugs are coming out very rapidly. I think that using genetic observations to look for novel targets for therapy has been very fruitful. I think PCSK9s are a wild success story and a rapid development program of effective therapy. And then factor 11, LPA, and others are coming. And then I do think that genetics to enrich for risk within clinical trial populations, or perhaps as the inclusion criteria for a clinical trial, shows a lot of promise as we think about enriching for greater absolute risk reductions and more favorable number needed to treat, and really personalizing therapy. Thank you.
Thanks, Mark. As always, that was just a very broad perspective and very thought-provoking. Just reflecting on the hope for a point-of-care test at the time of an intervention that would allow you to pick the drug that would be most effective at preventing, say, stent thrombosis. There was a lot of, obviously excitement and interest about that. And you pointed out that we just got better drugs, but we still haven't totally solved that problem. So I guess, reflecting on that a little bit, what about the concept of testing the physiology of thrombotic potential as we get ready to do interventions in any sort of way that's beyond just simple single genetics? There has been some work done in the past on that, but I guess I'm asking in a broader way, sort of, do you know of any data about more in silico testing or physiologic testing to optimize the treatment of patients at the time that they're hitting the lab, say, or about to get intervention, so that you could target, because obviously bleeding is still an issue, and surveillance intensity is an issue. So getting away from just the genetics, but to the bigger question of point-of-care testing.
Yeah, it's a great question. Actually, when the CYP2C19 data came out, there was another school, Dominic Angiolillo and others, that say, don't worry about the genetics, just test the platelet reactivity. Because there are all these other factors outside of the genetics that are, leading to angry platelets. Do they have diabetes? Do they have athero? And those things may add to the genetics or overwhelm it to some extent. And so I think your point's well taken that genes alone in that setting may not capture all of what you want to know when you tailor your therapy. There are, I think, people looking at this. Max Wohlauer is a vascular surgeon at University of Colorado, is actually collecting clot from people that come in with graft thrombosis and acute limb ischemia and trying to understand that biology. Others have tried a variety of different tests. And I don't think any of it's prime time. And part of the hard issue is that even when you look at platelet reactivity, you're looking at it in the context of one factor. I mean, we don't really have a global thrombosis test of tell me all of the factors that are leading to the thrombosis in this patient, whether it's coagulopathy or, procoagulant factors, angry platelets, endothelial dysfunction. How do you capture all of that in one test? But I think that would be probably the ultimate way to tailor then if you knew what was driving the risk.
I'm going to wear running shoes next year.
Yeah, no, I was going to thank you for running the microphone.
Yeah, of course.
You're getting more steps than everyone, though.
Mark, that was a great presentation. So, I couldn't help but see that, a lot of what you were discussing in terms of lipoprotein A, the cytochrome P testing, why hasn't this made it into our, mainstream clinical practice? I mean, the data is out there and it's really profound. Why isn't this standard of care? Why isn't it in our guidelines? How far is it along in terms of FDA approval? You mentioned the labeling change for clopidogrel, but are these not mainstream for a reason? Is there something that's stifling that progress? And then the other thing, in terms of POC testing and other forms of testing, where do you see lipoprotein A and other factor testing? Do you see it as a primary screen? Do you see it for diagnosis? Do you see it for prognostication or for delineating outcomes?
Yeah, great question. So the first one I'll say is, I'm always struggling to bridge the two worlds of the promise of big data and all of these things that we can integrate to make super personalized decisions, and the reality of my 15-minute clinic session for a patient that doesn't want to take any more drugs or maybe doesn't want to know, and they're worried about their back pain or their arthritis or other stuff. I mean, it's hard, and I think we have to recognize that people don't even calculate risk scores. I mean, Chad's VASC maybe for atrial fibrillation, but most, we get risk scores every day in journals, bleeding this, da-da-da. Nobody uses those. So then, you add genetics on top of it. And the problem is that for something to be utilized broadly in clinical practice, it has to be packaged in a way that is very simple and clear and impacts important decisions in a way that you can communicate with your patient and engage in shared decision making. We talked about genetic counselors. I mean, who Like, what are you going to do? So I think that's the issue, that we don't have broad genetic testing in cardiovascular clinics. Cancer is a totally different thing. I mean, it is crystal clear why you have to understand the biology of what someone's cancer. But for cardiovascular disease, we're just not there from a clinical perspective. And so then I think we have foci of people that are really good at this and use it a lot, and then there's like everyone else who's not using it at all. And I think that's the gap. I think the other issue is just when you get better drugs and it makes it simple, you don't need to adjust dose for 10As. You just prescribe, then who cares about what you do for warfarin unless you've got someone with an artificial valve, and it's just so infrequent that you don't need to do much about that. For the targets for lipoprotein A, you raise a really important point. I had the same thought during your talk of, biomarkers can be used to prognosticate, to risk stratify, and predict outcomes, or to actually select for treatment. I think LDL is actually not a great prognosticator. Right? When you look in acute MI populations, LDL is like a terrible predictor of it. But it is a risk factor. We know it's causal, so that if you lower LDL, you can improve outcomes. But other things sort of overwhelm it. I think lipoprotein A is the other. I think that everyone should get an LPA measured. You should know what your LPA is, because it is linked to risk, and it is something you can modify at least by LDL lowering and probably by LPA lowering. But in patients with PAD, I wouldn't say I need to know what their LPA is necessarily for treatment until we have therapies that can lower it, right? Once you have PAD, your LDL target should be less than 55 milligrams per deciliter. You're not going to be able to lower it much more than that already. So what else would I do? Some people would say add aspirin because it's prothrombotic. I don't think the data for that are very strong, to be quite honest. But if we get drugs that can lower LPA by 98%, then you've got a great opportunity to modify outcomes in those PAD patients. That's going to take prospective trials.
Hi, a great talk. This is not so much of a question, but an experience we're having in Michigan that is pertinent to this implementation question, where Blue Cross Blue Shield of Michigan has decided to start doing genotyping of 20 plus CYP genes for people who are deemed high risk according to criteria that I don't know if we know what those are or not. But what it's created for us in cardiology and anyone who's prescribing clopidogrel is that a person who is not on it may have a genotype, and you need to somehow link that to your decision to prescribe clopidogrel. So if it's a star 2 carrier, what are you going to do with that? So it's a question. I think we were talking about who to test, but in our scenario, it's just who has the data and what are you going to do with it? Yeah.
Yeah, so you're right. Clinicians may be forced to deal with it because they get it. My response to that would be like, just give them ticagrelor or prasugrel. But I mean, yeah, if they're on clopidogrel and they're not a responder, then it's probably good to know that. I think actually for PAD it may be more important because clopidogrel monotherapy is still class 1 in the guidelines, and you're essentially saying that somebody who's on clopidogrel monotherapy with a reduced function allele is getting nothing, and that might change. You could at least change them to aspirin or something else. Yeah. Great.
Thank you very much.